Hi everyone, and welcome to part 2 of the online session. Here we're going to talk about sleep diagnostics, methodology and procedures. So the learning objectives for this part is to describe and explain diagnostic procedures such as questionnaires, sleep diaries, polysomnography, polygraphy or type sleep, home sleep apnea testing, multiple sleep latency tests, maintenance of wakefulness tests, and actigraphy in the assessment of different sleep disorders. So in this part, we're going to talk about the different tests. We'll mention some applications for them, and then we will connect the dots more when we talk about the different sleep disorders in detail. We will also analyze the strengths and limitations of consumer sleep technology, such as smartwatches, and there will be projects where you are doing this yourself. So you will get more in depth in that as well during the course. Finally, we want to comprehend the strengths and limitations of automatic and manual sleep scoring. I will go into this briefly here, and this will then be done more in depth in the projects. So, how do we measure sleep? Can you think of anything before I show the examples? How could I be measuring your sleep? And here, when we think about measurements, we typically think only about objective measurements, something that we put on our hand or something that we place somewhere on our body to measure, but we don't necessarily think about our own experiences. And in this case, I think it's very important to think about both. So we can do sleep diaries. This is when you are asked about your sleep every morning after you sleep for at least a week, sometimes longer. And in the more extensive versions, you're asked also in the evening how your day was. We will go more into this and all of the different measurement types during this lecture. Then we have questionnaires, and this is also a measurement when we are asking you about your sleep. Typically here you're asked how was your last week, last month, or last 3 months. So it's not done every day for a period, but rather just once. Or for example, once in a baseline period while you are untreated for a sleep disorder, and then again after maybe 3 months on treatment to see if something changed. So these are the subjective ones. Also, we have the history taking of patients with MDs, and this is something that will be discussed separately. Finally, we have the consumer sleep technology. We'll go into how this measures sleep and the pros and cons, as well as activity monitoring. Finally, we get into the more medical sleep measurements, home sleep apnea testing, or HSAT as it is called, and polysomnography. And I will explain all of these different types and show you some examples of how it looks. Subjective measurements can also be called patient-reported outcome measures, or PROMs. And of course, we can also use this in general health, general population. So you don't necessarily have to be a patient for subjective assessment, but this is equally important when you are looking at patients as measuring things. So PROMs are patient-generated. You're assessing their health and changes in health when they are doing this themselves. This can include both sleep diaries and questionnaires. Oops. It is very important for patient participation and empowerment, and it actually enhances informed decision-making. So you have shared decision-making of the patient and the healthcare staff, and this has been shown to elevate the quality of care. And this is extremely important because the objective data that we measure may not show the same result as the subjective data. And when we think about things like sleep quality, when we ask people how they sleep or how they slept the night before, and then how our measurement is, they may not show at all the same results, and both are important. Here's an example of a sleep diary. There's a lot of different sleep diaries out there. This is, I believe, the most commonly used, the so-called consensus sleep diary, which was developed by standardizing this. There were many experts working together to standardize how we assess sleep. And there are a couple of different lengths of this sleep diary. The most extensive one asks questions both in the evening to ask about your day, if you were napping, caffeine, etc. If you think about the sleep hygiene talk, you're probing all of these different things. And then it asks in the morning how you slept, when you went to bed, how often you woke up, etc. There's also many sleep questionnaires out there. This is a book that was given out a few years ago and has some hundred questionnaires in it. It's quite interesting to read through because unfortunately many of these questionnaires are not validated. Some are widely used and others much less. And there is definitely a need for improvement in this category. But the most common ones that I believe are used are the Insomnia Severity Index, or ISI, which will be, I'm sure will be mentioned in the insomnia talks. We have the so-called Stop-Bang, which is to screen for obstructive sleep apnea. We have the Pittsburgh Sleep Quality Index, or PSQI, which measures the overall sleep quality, and you get a score, as well as the so-called Epworth Sleepiness Scale, or ESS. And this scale is most typically used to measure whether you have excessive daytime sleepiness. So here is this questionnaire. And now please press pause on my talk and answer this for yourself. So there is a scale from 0 to 3. How often do you doze or fall asleep when you are sitting and reading? And then there are 8 questions in total. So pause me, answer this, and count up your total score. The minimum is 0 and maximum is 24. And when you are done, see if you have a total of more than 10 points, because this indicates excessive daytime sleepiness. It doesn't tell us why you have excessive daytime sleepiness, but it does indicate that you do have it, that you fall asleep more easily than you should. This is not a perfect questionnaire, as is the same for all questionnaires. This is typically, for example, shows men's sleepiness better than for women. So women are more likely to describe fatigue and feeling tired, and they may feel sleepy, but they are not having as easy of a time as falling asleep. So they want to sleep, but they can't sleep necessarily. So it's not perfect, of course. But this is widely used. The limitation of all patient-reported outcome measures and subjective measures is memory bias. So it can help if you can do it digitally. We'll talk about this in the Sleep Revolution talks. And this is that you can digitally log events closer to occurrence. One of the issues, for example, with the sleep diary is that it's designed for paper. And maybe you're supposed to do this for a week and then hand in your sleep diary to a doctor at the end of the week, and then you realize you forgot to do it. So you just go in, answer for all of the different days, and there's no way for the doctor to know that you didn't do this daily, but rather at the end when you have forgotten a lot of things. Many of our questionnaires and sleep diaries are unvalidated or outdated and need improvement. And we need to think about how many of these we use, so because it can be a burden for the patient and participants in different studies. And it can also be a burden for the healthcare staff if there's a lot of different questionnaires they have to go through. And at the moment, there's no one sleep questionnaire that you can use, for example, for clinics or general population surveys to capture the whole sleep profile of a person. You really have to take a lot of different questionnaires that are designed differently. So they have different wording. Maybe one of them has 1 month of, you have to remember something that has happened in the last month, another one the last 3 months. Some of them have a don't know options, other not, and different formats. So it can be quite a burden for patients. If we then think about objective sleep measurements, so these are the typical subjective ones, we have different types. We have anything from a so-called type 1 sleep study, which is done in the laboratory. And in this one, you have electrodes on the scalp. You're measuring the brain waves, the eye movements, and the muscle tone on the chin. And think about now, why do we want to measure these 3 things? So this is for the sleep stages. We also are measuring your breathing, your oxygen saturation, breathing movements. We measure leg movements for a disease called periodic leg movements and restless legs. And typically we measure your oxygen, movements, activity, etc. And we also have a video camera and sound recording. So this is really the gold standard sleep study. We'll go into a bit later what are the possible limitations of it, but this is the what we consider the best one we have, because we're measuring so many things at one time, and this is attended. So if one of the sensors falls off, someone can come in and fix it so that the recording is as it should be. A type 2 sleep study is basically the same study without the video, in some cases with audio, it depends on the manufacturer, but you send the patient home and they sleep at home with it. So if a sensor will fall off during the middle of the night, there's no one to replace it. There are some positives, though, to doing it at home. And if you just think about it, to sleep for one night in a hospital, there's a lot of beeps, staff, strange pillow, strange bed. You may need to go to sleep at a time that you really are not normally going to sleep, like turning the lights off at 10, waking up at 7, and maybe you're a night owl. You typically don't go to bed until midnight. So there are pros and cons. But you can measure the sleep stages, etc., in both of these studies. So these are the polysomnography. Type 1 polysomnography is in the laboratory, type 2 is at home. Then we have something called type 3, and you can see that this the mannequin there has much fewer measurements on, and if you look at the head, you can see you don't have anything on the scalp. There's nothing to measure the eyes, nothing to measure the brain waves or the EMG on the chin. So we can't do sleep staging from this one. I'll show you an example of this a bit later. Type 4 sleep study is an even more reduced one. This can be, for example, just an oximeter or fewer sensors than you have in the type 3 study. We're also going to talk about the actigraphy, which is something that is typically placed on the wrist. It's wrist-worn, like a watch. And wearables, which can then either be a watch or a ring. And we're even starting to have something like T-shirts that you can put on and are full of sensors. So there are different types. And non-wearables is another example of consumer devices. So it can be something that's put under the pillow. It can be a radar on the night table. So there are more things out there. If we start with the consumer sleep technology, the benefits of this is that it is an objective measurement, and it is always good to have both the subjective and the objective, so you can verify what's going on, and you can have the different sides of the story for sleep. It is easy to measure for many days, and now there are wonderful data sets out there that people have been using for research, where you have maybe people being followed for a year or even more. So you can look at seasonal effects, you can look at the effects of the hormonal cycle for women, you can look at the effects of the daytime changes between summer and winter. So there are many things you can do with this. And it is measuring your so-called free living sleep. So you don't have all of these electrodes on as you do for the typical sleep study, the polysomnography. And you are sleeping at home or wherever you're normally sleeping. You can go on trips, etc. And it's not just in hospital for one night, which it can be very unnatural sleep. And this is, of course, used widespread. So there are benefits to this, and we can use it for many things, but it is also limited. It can overestimate your sleep and underestimate your wake, and this is quite typical because these sensors are, of course, not on your scalp, so they're not measuring brain waves. They are measuring movements on your wrist or finger, and it's measuring your heart rate. And if you remember from the sleep stage discussion, then in, for example, deep sleep, you have slower, more regular heartbeat, while in dream sleep, you have more irregular heartbeat, and also in wake that it's faster. And typically in wake, you're moving your hands more, and you're doing this less when you sleep. But what happens here is that, for example, if you're just watching a show on Netflix or something, and you're not moving, it's very likely that this device will say you are asleep. And if you're an insomniac who's really trying to fall asleep, and I told you in the sleep hygiene talk, you can't really force yourself to fall asleep, but this is typical that people are trying this, and then you will lie absolutely still. And because you're lying absolutely still, it's very likely that this consumer sleep technology will think you are asleep while you were indeed awake. And for the sleep stages at the moment, most of these wearables are not able to capture your sleep stages, because if they measure your heart rate, very often they only measure it for small periods of the night. So if you're only looking at movements, it's not enough to really classify sleep stages correctly. But we are getting devices that are getting more and more battery, more and more memory, because these are, of course, limiting factors, and they're starting to put more sensors in one device. So as soon as we start getting, for example, movement and heart rate and skin temperature and something called electrodermal activity, which is different depending on sleep stages, and you're sampling this in a big enough fashion, you can really start to get sleep stages from these devices. So I think this will be very exciting to follow in the future. And while at the moment you have to be careful. And yes, there is very little validation typically at the moment. Many of these devices, they're overextending themselves, saying they can measure many things that they can't really do. For example, it's quite typical that there's some sort of a sleep score, and people can panic about this, that all of a sudden their sleep score was only 85, while it's normally over 90. But we don't really know where this comes from, and it's not validated. So we don't really know what it means. Typically, it's also a black box analysis. So we don't know the algorithms. This is company products. We can't validate and test exactly the algorithm behind it, and you are not measuring the actual signal. If you think, for example, about sleep stages and what you need to measure sleep stages, which is then on the top on the head, and in most cases this is just on the hand or finger. So, and it's the same if you're looking at breathing. Typically, you're not measuring breathing, but the changes in the pulse because of breathing. So the pulse wave. Finally, for this, we're going to split this in two parts. So this is the last slide for the first part. Then please take a small break, get a coffee, stand up before you listen to the second part. And this is the so-called activity monitoring or actigraphy. So this is, again, a watch that is on your forearm. And typically it also has a light sensor. So you can actually see if people if they're outside, it's daytime, they have their lights turned on. You can see the different lux. That's the yellow line there. And then when they are in darkness. The issue here can, of course, be that you have something placed over it. So either you're wearing something that goes over it, or it's underneath the covers, and then you don't really see if the person has a light on. But you can see here 2 areas in blue for the 2 different days when there's very little movement. So again, this is based on, it's a movement sensor primarily. But you can see also the lux, and in some of these devices you can also have the skin temperature, so you can see when people have taken it off and when they're actually wearing it. Because there can be periods, like early in the first day that is shown there, where you don't know, did the person take a nap or did they take it off? And it's good when you have the skin temperature for this case. So this, importantly, is validated for medical use. And this means they're not going to change the algorithm in the device without testing it against the gold standard data like a polysomnography, unlike the consumer devices where they can change the algorithm whenever they want. And they don't need the same amount of validation if you are selling to consumers directly than you do for a medical device. However, the benefits and limitations are similar to the consumer devices. You are still not measuring actual sleep, and you may be overestimating wake quite a lot and not get as much sleep. And you're not able to do sleep stages from this device. So let's take a short break here, and we'll start again. There's a part 2 for the second half. Thank you.